I'll go ahead and introduce our speakers, and they can come up here and take a seat. First, I'll go over all of the little notes that we go over at the beginning of every session. So remember to complete all of the pre-tests, post-tests, and evaluations on site so you don't have to do them when you get home. The presentation slides will be available on the mobile app if we get permission from the speakers and the portal. Share your experiences on social media with the hashtag NKFClinicals. If you are not a member of NKF, please consider joining. You do get a significant discount on attendance at our sessions. And we'll get started on the intros. So our first speaker is going to be Dr. Leila Zelnick. She is a research associate professor of medicine, nephrology at the University of Washington and the director of biostatistics at the Kidney Research Institute. She was also recently named a fellow of ASN. Dr. Zelnick received her PhD in biostatistics from the University of Washington in 2015. She served as statistical editor at the Clinical Journal of the American Society of Nephrology from 2017 until 2024, and currently serves as statistical editor for the American Society of Nephrology portfolio of journals. Dr. Zelnick has helped design and analyze numerous observational studies and clinical trials, and has published over 130 peer-reviewed manuscripts, primarily in the areas of nephrology, endocrinology, cardiology, and critical care. We're good? Thank you. And I just got the okay that our slides are all set, so you can come up, Leila. And you can come up too, Ian. And our second speaker, and then they'll kind of tag team after that, is Dr. Ian DeBoer. He is a professor of medicine, director of the Kidney Research Institute, Joseph W. Eschbach, MD, Endowed Chair in Kidney Research, and an adjunct professor of epidemiology at the University of Washington in Seattle. He is also a staff nephrologist at Veterans Affairs Puget Sound Health Care System. Dr. DeBoer's research focuses on the causes and consequences of diabetic kidney disease. Particular areas of contribution include the epidemiology of diabetic kidney disease, prevention and treatment of kidney disease in diabetes, metabolic abnormalities in chronic kidney disease, and mineral metabolism and cardiovascular disease. Dr. DeBoer has published over 450 manuscripts in the field. He has also helped translate research into clinical care through clinical practice guidelines, including the American Diabetes Association's Standard of Medical Care in Diabetes and the KDIGO Clinical Practice Guidelines in Diabetes and CKD. Welcome to both of our speakers. And everything good to you? Yeah, no. Great.
Thank you. Thank you for that warm introduction. Thank you to all of you for being here, despite the wild weather happening outside. These are our disclosures. As Marlene pointed out, I am a statistician, not a clinician, so I'll bring that lens to the things that I'm talking about today. So we have two learning objectives for the day, and I will focus on the first one, which is to understand the strengths and weaknesses of glycemia biomarkers for assessing glycemic burden in dialysis patients. And I'll leave number 2 to Ian. So we'll start out with, just to put us in the frame of mind, 2 different patients with diabetes and CKD. These are 2 actual participants in studies that we have done at the University of Washington that I'll be talking about later. So our first participant is a 60-year-old woman with stage 3 CKD due to type 2 diabetes. She has an eGFR of 40 with macroalbuminuria, a history of retinopathy, stroke, and hypertension, and importantly for the talk today, has a measured HbA1c of 8.4%. So we'll contrast her with a participant from our Blossom study who's a 79-year-old woman with kidney failure due to her type 2 diabetes, who's been on in-center hemodialysis for 5 years. And she has a lab glucose of 128, or on another occasion measured as 147. Her HbA1c, however, is measuring at 5.8%. So as we go into the things that we're talking about today, I just invite you to think about how might you manage these patients clinically with respect to their glycemia, and you can revisit this later to see the extent to which this should or should not happen. So why are we really even here today? Well, it turns out that chronic kidney disease compounds the adverse effects of diabetes. So we know that diabetes can lead to both hypo and hyperglycemia, which can lead to bad outcomes, hypoglycemia, things like accidents, falls and fractures or arrhythmias, while sustained hyperglycemia can lead to complications with respect to kidney, eye, nerve, heart, and infections. And chronic kidney disease is compounding all these. People with chronic kidney disease have fewer medication options. For those drugs that they are able to access, they have reduced drug clearance. There's also decreased renal gluconeogenesis that occurs. And relevant to today's talk, it turns out that measures of glycemia, like HbA1c, can be inaccurate in people with CKD. So I would like to just pause for a moment and sort of define the scope of what we're talking about. Okay, so average blood glucose, I'll say that phrase perhaps multiple times today. And what I really mean by that is if you could measure somebody's blood glucose at every time point, or say every 5 minutes, with a continuous glucose monitor, if you could average that over time, what would that be? That's really the kind of the gold standard that we're trying to get at with these biomarkers. So the real kind of guiding star question that I'll be thinking about is to what extent can a biomarker recapitulate that mean blood glucose that you would get from a CGM? So we have our first polling question that we've, and it's working. Wonderful. So I invite you to scan the QR code here and answer the question, which of the following biomarkers correlate most closely with mean glucose in patients with CKD, including those treated by dialysis? So there's hemoglobin A1c on here. There may be other biomarkers that you may be less familiar with. That's okay. Fructosamine has taken an early lead here, but there's also glycated albumin, 1,5-anhydroglucitol, or you could say none of them work. That's also an option. So we'll give everyone a few more moments to participate. I love this part.
It's worth the wait.
Worth the wait. All right, so the wisdom of the crowd says that fructosamine is the most closely correlated. So I invite you to tuck that in the back of your mind, and we'll go through the evidence to support that. Well, I'll start with some bad news, or perhaps just tell you like it is that all biomarkers that I'm going to talk about of average blood glucose have substantial limitations. Okay, so for one, we are really looking at mean blood glucose. So none of these biomarkers that I'll discuss today can reflect glucose variability. Okay, they can't quantify hypoglycemia. Those are other tasks that need other tools. Likewise, they can't be used for real-time glycemic management. Only A1C has been evaluated as a therapeutic target in large clinical trials, but even there have not been any large trials in people with CKD or kidney failure. And all of the biomarkers that I'll discuss today are biased by factors that determine post-translational modifications. Okay, what does that mean? Well, it can lead to substantial imprecision when you're estimating the mean glucose, and those problems are likely worse in people with more advanced disease. Why do we even need biomarkers in CKD and kidney failure? Why do we even care about these? Well, we don't necessarily care about biomarkers for their own sake, but a biomarker such as A1C, glycosylated hemoglobin, is a measure of the average glycemic load over the last 2 to 3 months. And we care about that in as much as it's considered a validated surrogate endpoint for clinical trials of glucose-lowering drugs in diabetes. And what does that mean? That says that if I have a treatment, an intervention that can lower someone's A1C, that correspondingly it will lower their risk of hard clinical outcomes that we really care about. So I'm showing you this. Oh, dare I have this? Oh, yes. Okay, I have this figure over here from a previous paper, a meta-regression. So each of these circles represents a clinical trial. The bigger, let's see, they're weighted by the size. So, for example, a trial that had a reduction in A1C of 0.5% correspondingly would reduce a person's risk of non-fatal stroke by about 10%. So this meta-regression is showing that larger reductions in A1C correspond with larger reductions in the risk of stroke. But it's complicated. In people with CKD and people who are treated with dialysis, A1C is problematic. This on the left here is a distribution from a group of almost 25,000 Fresenius patients who were treated with hemodialysis who had diabetes, the distribution of their A1Cs. Now, I know these numbers are small, but I will tell you that about 2/3 of the people that were surveyed had an A1C less than 7. For those of you who are clinically active, I hope this is somewhat surprising to you. It's not what we think of when we think about people necessarily with diabetes. Also complicating the picture is the association of A1C and mortality among people treated with dialysis. This is from a cohort of DaVita patients with diabetes. And you can see there's this clear U-shaped association, so that among people with diabetes, people that have very low A1Cs have a risk of mortality similar to people with very high A1C. That's strange, and that's unusual, and that's not what we see in a general population. So, hopefully your spidey senses are tingling at this point, saying, like, what is going on here? We also see evidence that A1C tends to be falsely low among people with kidney failure. This is an older study from 2008 looking at a cohort of patients with diabetes, most of whom were treated with hemodialysis. And this figure here shows that for any given level of glucose, people who were treated with hemodialysis had an A1C that was about 1% lower than people who were not treated with hemodialysis. They also found that A1C was lower among people who used EPO. Similarly, an even older study from 1998 among a cohort of patients without diabetes in Japan who were initiated on EPO over 20 weeks found that as EPO was administered, hemoglobin went up, surprisingly. A1C correspondingly went down about 1%. And then when EPO was stopped, the reverse happened. And importantly, all throughout this time course, the true glucose of these patients never changed. So you can see that EPO is having these dramatic effects on this biomarker of glycemia that we trust, or perhaps trust. And perhaps the final nail in the coffin in my mind is this other study from 2010 of people, a small cohort of people with CKD, stage 3B or 4, and type 2 diabetes who were already going to start either IV iron or an ESA. And they did a pre-post design where they looked at these markers of glycemia before administration and after administration of either IV iron or ESAs. And you can see that the IV iron administration made hemoglobin A1C go down by about 0.4%. That was statistically significant. The administration of ESAs made A1C go down by about 0.7%, also statistically significant. And importantly, the mean blood glucose in both of those cohorts of patients did not change. So it seems to be something about the ESA, the iron administration. The reason for this is that ESAs actually cause an increase in the number of circulating red blood cells, young red blood cells, which have then less opportunity to be glycated. I like to think about this, again, not as a clinician, but as a parent of young children, to say that if I invited my son's third grade classroom into the room here and then asked you what's the average age of this room, it would be, one, much lower than it is right now, and two, perhaps not reflective of what we really want to measure here, the age of this room. So this slide just summarizes what we know about A1C in people with chronic kidney disease or kidney failure. So we know that there are mechanisms of bias related to the shortened lifespan of red blood cells. Again, there are a higher number of immature red blood cells, which means that they have less opportunity to be glycated. There also can be actual physical damage of the red blood cell by the hemodialysis procedure, which can also further bias things. Now, I mean, it's not all bad, right? A1C is widely available. There are NGSP standardized assays, so we know that when we're getting an A1C, it's going to be the same one as we would get from a different lab. And there's quite a lot of clinical trials outcomes data that's reliant on A1C, not particularly in people with CKD, but perhaps we can extrapolate that. So we know the limitations, they're out there, maybe now we can deal with them. And so most of these biases, not all of them, but many of them relate to things related to the red blood cells, things like anemia, blood transfusions, the use of ESAs, as well as a few others. Okay, so hopefully I've convinced you that A1C is not where it's at. Maybe you want to get excited about other measures of average glycemia. I can tell from our poll that many people in the room are excited about fructosamine. So fructosamine is the product of glucose and circulating amines. It's reflective of glucose over a shorter period of time, the last 2 to 3 weeks instead of the last 2 to 3 months. So it may reflect changes in therapy more quickly. And importantly, from the point that I've hammered home in the last few slides, it's independent of red blood cell turnover. Similarly, glycated albumin is the product of glucose and circulating albumin, reflective of glucose over a slightly longer time frame, 3 to 5 weeks, and also independent of red blood cell turnover. These assays are not internationally standardized, and the literature assessing associations is less developed, I would say, than for A1C. In particular, there's no trial data testing it as a therapeutic target. And I'm sorry to say that aside from spring clinical meetings, there's no free lunch, that these biomarkers can be affected by protein turnover, not red blood cell turnover, but protein turnover, things like proteinuria, hypoalbuminemia, and cirrhosis. Finally, our poll mentioned 1,5-AG is a chemically stable monosaccharide whose levels are stable when people have normal blood glucose, but it competes with reabsorption. So in people with diabetes who have high glucose, this 1,5-AG will go down. That means that this biomarker is actually a biomarker of glucose excursions in the previous 1 to 2 weeks. So a measure of glucose variability, not of average glucose. So I'm going to kind of set this aside from the biomarkers that we're really discussing today. Okay. So we have a pair of studies that we will assess these biomarkers in. The first is the CANDY study, which was a study of 105 people with type 2 diabetes, most of whom had CKD and a small number of controls. Importantly, no one in the study was on an ESA. And I'll also introduce the BLOSSOM study, which we conducted at the University of Washington with participants from the Northwest Kidney Centers who are treated with maintenance hemodialysis or peritoneal dialysis, both with and without diabetes. We asked these people to wear a Dexcom G6 Pro CGM for a median of just over 9 days. Importantly here, about 2/3 had diabetes, and about 75% of people were using an ESA. So I'll just give you some color from those two studies. So first of all, in each of these studies, we have both gold standard CGM measurements and these three biomarkers that I've introduced: A1C, glycated albumin, and fructosamine. So first off, we found that one biomarker measurement tends to be enough over about 3 weeks. So 3 weeks apart, we measured each of these biomarkers. You can see there's very strong correlation both in people with CKD and people on dialysis. So this is good. That means that if you are trying to measure this clinically, you don't need to do it every single week. You don't need to do it every 2 weeks. You know, even 3 weeks, one measurement is enough. Second, we found that all of the biomarkers were strongly correlated with mean glucose in the CANDY study in CKD, with correlations ranging from 0.71 to 0.77, and all pretty similar in CKD. Among patients treated with dialysis, we saw a little bit more difference. Fructosamine was the least correlated with a correlation coefficient of 0.7, and glycated albumin and A1C both had substantially higher correlation, 0.85 and 0.87. So I'm afraid I'm not sure anybody in the room got that quiz right. That's okay, we're all learning here. Previously we thought that there was some evidence that these biomarkers might be less precise in advanced kidney disease. This is showing a number of different studies ranged by the stage of kidney function from non-CKD all the way to dialysis. And if you squint your eyes, you can maybe see that they're getting less precise over time. That's not, in fact, what we found in the CANDY and BLOSSOM studies, that we found pretty strong correlations there. Okay, the last thing I'd like to talk about is bias. So we know that they are correlated, but then we want to say, are they biased? So in a pair of publications, we looked at these in these two studies, and we found in CKD that A1C had few biases, but that glycated albumin and fructosamine had substantial biases, in particular by BMI, albumin, albuminuria, and iron. So what do I mean exactly by biases? Well, I'll just say that, for example, glycated albumin, for two people that have the same true level of mean blood glucose, if one of them has macroalbuminuria and one of them doesn't, the person who has albuminuria will show a lower biomarker of glycemia, even though they really have the same level of glycemia. We did the same thing in the BLOSSOM study among people treated with dialysis, and here we found substantial biases in all of the biomarkers. I forgot to point out in the CANDY study, I said we didn't see any or very many biases with A1C, but remember that none of the patients there were being treated with an ESA. Here, many patients were, so we saw some substantial biases with body mass index and ESA dose. For glycated albumin and fructosamine, the biases were more related to things like modality, dialysis vintage, and residual kidney function. Now, I've nattered on quite a lot about bias and precision, so I'd like to just take a step back and talk you through why I care about those things and why I think you should care about them too. Okay, so you may have seen this picture before. These are a series of 4 bullseyes, and the way I think about these is I think about bias on one axis and then variance on another. So by bias, what I mean is, on average, am I hitting the bullseye? Am I getting the right answer on average? Okay, ideally, yes. But then the other way that I think about it is, am I getting the same answer over and over again? If I measure somebody's glycemia today and tomorrow and a week from now, am I getting the same answer or am I getting different answers? Ideally, we would be in the situation where we have low bias and low variance, but I claim that the second best place to be is to have high bias but low variance. And here's why. Okay, we saw that the correlations of all these glycemic biomarkers with mean CGM were pretty good, high correlation, even in patients treated with dialysis. So that tells me that we have low variance. We're in this top row. At the same time, all biomarkers are biased, but they are known and thus they are estimable. I can figure out how far am I from the bullseye over here. If I can do that, if I can figure out how long is that arrow, then perhaps I can correct the A1C. Maybe I can come up with some kind of a bias-corrected A1C that would give me back the true answer reliably. So, in summary, we've seen that biomarkers of average glycemia are strongly correlated with mean CGM glucose. They're repeatable over about 3 weeks, so you only have to get one biomarker measurement. Unfortunately, all biomarkers have biases in advanced CKD or kidney failure. For A1C, those biases are primarily related to things related to red blood cells, such as use of ESAs, anemia, or IV iron. For glycated albumin or fructosamine, those are factors that influence albumin or protein turnover. None of them capture glucose variability for short-term care. That's just sort of baked in. And so there's work to do that could be potentially complicated. Things like trying to bias correct these biomarkers, and larger work about finding associations with clinical outcomes, and perhaps on down the road, kidney failure specific trials that target biomarkers, something like that. Okay, I will pause there, turn it over to Dr. DeBoer to talk about our second learning objective.
All right, thank you so much, Dr. Zelnick, and thank you all for coming. I add my thanks to Leela's today. Hopefully the storm is calming down by now, and by the time we're done, we'll see. So I'm going to start similarly to Dr. Zelnick with the big picture, asking why are we talking about glycemia in patients with dialysis, and for me, the elephant in the room is this question that always comes up: does glycemia matter for dialysis patients? And there's this nihilist viewpoint, this devil's advocate view that holds that A1C is inaccurate, as Leela noted. Maybe it's too late for glycemic control. The kidneys are shot already. Glycemic damage is already done. Dialysis patients are too morbid and too complex. We should just focus on avoiding hypoglycemia, but not bother with glycemic control more broadly. And these patients have bigger fish to fry. And these are the devil advocate view. I think that there is a sort of an approach now of the ostrich in the sand. People don't look so much at glycemia because we don't know that it's important. We don't know what to do with it. And it's just not a central focus of dialysis patient care right now. But I don't know that it has to be this way. And what if we can accurately measure glucose, maybe with biomarkers? We can improve those. Maybe there are other ways, like continuous glucose monitoring or CGM, that I'll be speaking about this next 20 minutes or so. What if we could control glucose and decrease risk of diabetes complications other than the kidney? Of course, our patients with diabetes are at risk of blindness, neuropathy, things that really impact quality of life, stroke, and myocardial infarction. If glucose control can improve these things, we absolutely shouldn't forget about it. What if we can do this without causing severe hypoglycemia from our medications, and what if we can develop new paradigms to accomplish these goals? I don't have answers to all these questions. We're not there. We can't do these things, but I think we're moving closer, both with the clinical chemistry that Leela talked about, and also the very exciting area of continuous glucose monitoring. And so that's what I'll focus on next. And many of you know the CGM technology has really exploded over the last 10 years or so. Here are some of the devices that are available now. On the top are the two most commonly used devices in the United States, the Abbott FreeStyle Libre 3 and the Dexcom G7. These have sensors that are inserted into the subcutaneous space. They measure interstitial glucose. They're usually placed on the back of the arm, though they can be on the abdomen and other places in some situations. The results are transmitted to a receiving device, either a dedicated receiver. I don't think this is showing up. I need to use this, don't I? This is the dedicated receiver, or they can be synced with a smartphone or watch here. There are other devices available too. This is the sensor that was used in the CANDY study, and this is an implantable sensor that can be left in for 6 months. These read now for 15 days at a time and need to be changed. These can last 6 months. All of these can be used in different modes. Personal CGMs that patients get on their own are generally reading out real time, so they can see every 5 minutes what their glucose is and what direction it's going. There are also professional versions that are administered by clinics that can be either real-time or blinded. And blinded is the mode that we've used in the research studies that we're talking about. This flash technology is less common now, but it's also still available. These are, this is out of date actually, so Medicare actually covers CGMs for people with type 1 or type 2 diabetes who use insulin of any type, any number of injections per day. It no longer has to be 3 or more insulin injections a day, but if you use insulin, Medicare covers CGM. Now, this technology, of course, can get very powerful when it's automatically coupled with insulin delivery. So for people with type 1 diabetes in particular, and also people with type 2 diabetes in some situations, the CGM is connected with an insulin pump in an automated insulin delivery system, and this is the most advanced way now to control blood glucose. What's also really helped this field is a standardized way of interpreting the quantifiable, or the large quantity of data that come from CGM devices. This is called an ambulatory glucose profile. It's been standardized, and all devices can be used to create this profile. So Leela showed something like this earlier as well. This is a summary of multiple days of glucose measurements over time from midnight to midnight. You can see this person starts high, they go low in the morning, up higher in the afternoon. Sort of the distribution around those averages. There's a range that's considered the target range. So for people with diabetes, that's usually called 70 to 180 milligrams per deciliter. And then we can use these data also to report clinically useful metrics that can be followed. The time in range, so 70% is oftentimes sent as a target, time above range, time below range, mean glucose, which Leela was talking about in relationship to the biomarkers, as well as metrics of glucose variability. Now, these devices, I have to say, are not officially approved for patients with dialysis, and the FDA indications in the label say that's the case. Why is that? That is due to theoretical concerns that they may not work as accurately in patients with dialysis as in the populations for which they were developed. That's diabetes with normal kidney function. Why is that? There are really two theoretical concerns. One is about interstitial volume expansion, and of course our kidney patients and dialysis patients have expansion of volume that is in the vascular space, the interstitial space where CGMs are monitoring. Is that thunder? I don't think that's thunder. That's thunder of the rolling variety, I guess. And then these third spaces that are less available. So the concern with dialysis patients is when all of these spaces are expanded, perhaps the interstitial space is not equilibrating as well and capturing what's happening in the vascular space as well as it does with normal kidney function. And then on the right is the other concern that's come up, and this is really specific to peritoneal dialysis, and when we use icodextrin as a dialysate for peritoneal dialysis patients. That is a complex polysaccharide that is broken down. It is absorbed, and when maltose is broken down and then absorbed into the blood, it circulates as a disaccharide that in older CGM systems and also fingerstick systems could be counted as glucose. That was the truth, happened in these older glucose dehydrogenase assays. The sensors I showed on the prior slide use a glucose oxidase method that should not be susceptible to this. But these are the concerns. And here is another polling question, so please open your Slido. I was just wanting to know if anyone in the room here has ever prescribed or administered continuous glucose monitoring to patients treated with dialysis. And you can see the options there. It's a bit of a tricky question. I'm sure this is a very diverse audience, I'm sure. Not everybody prescribes things in general. That's fine. And it's also tricky in that, as I noted, these are not FDA approved. There are a number of concerns, but I'm curious what we have. All right. All right. Good. Nobody lots of times. I'm not surprised at that. I'm not in that category either. I'm probably in the occasional category myself. This is something that really hasn't penetrated care yet. I think that may change in the future, and we'll see some of the reasons why. Thank you for your answers. So I'm going to show some data that addresses some of the questions that we've brought up, and they're all from this BLOSSOM study that Leela introduced. This is an observational cohort study. The whole study included 420 people. They all wore a Dexcom G6 Pro CGM for 10 days at baseline, and then were followed up in various ways. There are subsets that did additional activities. I'll start showing some accuracy data from a subset of 12 people. Leela talked about the glycemia biomarker study in the last talk, and then I'll also talk about another subset of 20 people who did what we call this hormone study. So the accuracy sub-study, 12 great volunteers wore at the same time a blinded G6 Pro, a G7, and did fingerstick blood glucoses with a study-administered glucometer. And the goal was to ask the question, how closely did the two CGMs correlate with fingerstick blood glucose? And the answer was pretty well. So on the left is the G6 Pro versus fingerstick. Right is the G7 versus fingerstick. And then these are the two CGMs versus each other. And the correlation is high. In the CGM world, there's this quantity called the mean absolute risk difference, or mean absolute relative difference, or MARD, which the target actually is less than 10%. And in these dialysis patients, it was not reaching that level, but it was acceptable. And I think there are reasons we can potentially discuss as to why, given the design, the levels were not quite at that level, but they weren't bad. And this is called an error grid that, again, plots the CGM values versus what's considered to be the gold standard, the fingerstick values, and says, are they in a highly concordant area, green, or an area green or yellow, where clinical decision-making is adequate, or are they in risky areas where if you made a clinical decision based on these values, you might have problems. And the good news was that 97 or 98% of the values were in the green and yellow zones, so not bad for clinical decision-making. And actually, there are quite a few studies, like our small study here, that have similar results. This is one from California that also looked at hemodialysis patients, tested the same sensor, compared it to fingerstick blood glucoses, as well as venous blood glucoses, and found MARDs in the same range. One question you might have is, well, is this affected by dialysis? Is it different on dialysis days or non-dialysis days? They looked at that, and it was pretty similar on both days. And there are more studies that I won't go into now. So next I'm going to go to some of the findings, the descriptive findings from this whole BLOSSOM study about when we put CGMs on dialysis patients, what do we see? So I'm asking you to guess now, what do you think is seen? This is 420 patients in Northwest Kidney Centers in Seattle, all wearing a blinded CGM for 10 days. What do you think we're going to see? All right, a lot of people see a lot of variability. Frequent hypoglycemia, all right, a little bit of everything. Okay, great. Highly variable blood glucose is the reigning champion here. Let's see some data. So this is sort of the table one. This describes the 420 people on dialysis. They're very diverse in terms of gender, race, ethnicity. We also, I should point out, had 94 non-dialysis control subjects. So these were patients without known kidney disease and without diabetes. I also want to point out among the people with diabetes, well, first of all, as Leah has said, about 2/3 had diabetes, about 1/3 had no diabetes. Among the people with diabetes, 2/3 were using glucose-lowering medications. 1/3 were not using any glucose-lowering medications. And this is a well-described phenomenon. These people may have had diabetes for decades, but when they reach kidney failure, their hemoglobin A1Cs go down, something changes, they come off medications. People think that perhaps their diabetes is improved. It's a very interesting group. We call that untreated diabetes, trying to be non-judgmental about what's going on in that phenotype. So this is a descriptive data now looking at throughout the day. This is sort of these are mean glucose values averaged across all the days in dividing this BLOSSOM population into 6 groups. Hemodialysis patients on the left, peritoneal dialysis patients on the right, and then 3 groups. So the bottom line in each one is people without diabetes. So this is hemodialysis patients without diabetes, and this is actually pretty normal. Lower in the morning, rising when you eat throughout the day, and then coming down overnight. At the top are people with treated diabetes. These people are on mainly insulin, as you may have seen. Their blood glucoses are quite high. So their average blood glucoses throughout the day are well over 200 milligrams per deciliter. What about that untreated diabetes group? They're here. They're certainly not normal. They're not as bad as the treated diabetes, but they're certainly not normal. They start above average in the morning, and then throughout the day, they have these sort of prandial-related hyperglycemic. So they're not responding to meals. They're not able to control what they're eating. Peritoneal dialysis, moving over there, we'll start with those without diabetes. Pretty flat, but look, it's elevated compared to the hemodialysis by about 30 milligrams per deciliter. This is probably due to the dextrose they're getting in dialysate. The peritoneal dialysis patients, even without diabetes, basically lived out of the normal range most of their life in this study. And you can see here, this is the treated diabetes on peritoneal dialysis, which is the worst controlled group in the study. Here's some metrics, again, for these 420 people. On the left is mean blood glucose. So here's the normal range. Now we have the normal people here. So normal mean is around 120 here. And the mean for hemodialysis patients without diabetes was about the same. But again, clearly higher for peritoneal dialysis patients, higher yet for untreated diabetes, and then the treated diabetes patients the highest. So here, for people who are looking for variability data, you were right, at least in part. Oh no, I don't have the variability data here. There is more variability with the dialysis patients, particularly hemodialysis patients. This is time and range. I'm going to focus on the bottom. These are people with diabetes, where 70% time and range is sort of the treatment goal. And you can see, especially people with treated diabetes, they're generally not making that goal. So for the people who voted for uncontrolled hyperglycemia, I actually think that probably was the most common finding that we saw in this study. All right, I want to quickly talk about the effects of our dialysis procedures as seen in this study. And so this is looking only at hemodialysis patients. And instead of looking from midnight to midnight, This is a temporal curve anchored on the end of dialysis. So most patients are having hemodialysis for 4 hours, from -4 to 0. We're looking at the average blood glucoses in these same 3 groups. And you can see even people without diabetes, they tend to go down during dialysis, and then afterwards they have this jump up, which we've called a rebound. That's seen also in the untreated diabetes and the treated diabetes, where the effects are largest. And just to make sure this isn't a time of day phenomenon, we looked at the same matched the day period by time, and on the non-dialysis days, there's no such effect. So we've seen this decrease during dialysis towards 100 milligrams per deciliter, which is the dialysate concentration, with a rebound afterwards. The degree of rebound was higher in people who had diabetes, used insulin or sulfonylureas, who had shorter dialysis vintage, came in higher before dialysis and dropped more during dialysis. So we were wondering what the heck is going on. Is it eating? Could be, and we don't have great food records for these, so eating could be part of it, but we think there's more. And we've hypothesized that maybe this is due to disruption of glucoregulatory hormones. We don't have firm evidence of this right now, but we did, in this 20-person subset, on 2 hemodialysis sessions, measure 8 critical glucoregulatory hormones before and after dialysis. Some of these you'll recognize, like insulin here, of course. These are the incretin hormones, GLP-1, GIP. And what I want to show here is that all of these hormones drop quite substantially during dialysis. So we have a very complex glucoregulatory system to control glycemia. It facilitates glucose uptake into cells, et cetera. And essentially with dialysis, we're wiping it out. We're just removing all these hormones. And we theorize that disruption is leading to sort of a chaotic state after the dialytic period, which is leading to this hyperglycemic rebound. I'll note that the degree of rebound after dialysis correlates with hemoglobin A1C and time in range. So people who tend to be rebounders have worse glycemic control overall and less time in range. And then I'll move now to peritoneal dialysis. You're probably interested in what happens there. So these are peritoneal dialysis patients stratified by their diabetes type, either none or with diabetes, and by the amount of dextrose they have in their dialysate. And what I'll just point out is people who use more dextrose in the non-diabetic group tend to have higher glucose, and in the diabetic group also tend to have more glucose. So this is not rocket science. People for whom we're prescribing more dextrose overnight tend to have higher glucose during the night and actually throughout the day. I'll say that we do see hypoglycemia in these patients as well, quite a few events, less than we anticipated. Again, more hyperglycemia than hypoglycemia. We don't yet know the implications of this hypoglycemia or the hyperglycemia for that matter. All right, so I'm going to stop and say my summary. CGM actually is accurate for patients treated with dialysis. I've shown you some of the data. Again, not fully approved, but I think some of the theoretical concerns that have been brought up seem not to be major drivers of problems. Among dialysis, CGM reveals substantial unexpected glycemic abnormalities. So I think the biggest finding we saw was actually the substantial unrecognized hyperglycemia. We do have unique effects of dialysis procedures that I think mean we should understand this in more depth. We do see hypoglycemia, I didn't say, but that's most common actually without diabetes. And we do need more work in this field to understand whether these abnormalities are associated with clinical outcomes and whether we can therapeutically intervene to improve outcomes. So I'm going to stop right now. I have a thank you slide. Thank you all for coming, and to the National Kidney Foundation, Dr. Zelnick, for presenting together. This is the Kidney Research Institute group that's done a lot of this work. And I think we'll move into case studies. And we want these case studies to be interactive. So if you have questions about the cases or questions about the cases and what we've talked about, we have microphones and hop on up. So Leela, I think you're going to start with case number 1.
All right. So case number 1 is closely related to somebody that we saw earlier in the talk, so I won't spend too much time going through the background. But this is a 56-year-old woman with kidney failure due to type 2 diabetes on in-center hemo for 3 years, is not currently using insulin, but is on an ESA dose of 100 micrograms every 2 weeks. Okay, she has a lab glucose of 123 and a measured A1C of 5.8. This is her ambulatory glucose profile, which Ian showed previously. Ian, you stole my pointer.
Sorry.
I was just going to point out here that you do see quite a substantial amount of hyperglycemia later in the day. In the morning, it's within the target range of 70 to 180. That said, her average glucose was 228, averaged across all times, and her glucose management indicator, which is, you can kind of think of like an A1C that's measured from the CGM, was actually 8.8. She was also 68% of the time above range, above 180. This is somebody from our Blossom study, so this is a plot of everyone from our Blossom study, their GMI derived from the CGM versus the measured A1C. You can see she's the blue triangle here, that although her A1C was measured at 5.8, her GMI was actually about 8.7. And then finally, looking at the progress of her CGM day on day, you can see these high excursions of hyperglycemia, probably corresponding to meals. This person actually was on dialysis on Tuesday, Thursday, Saturday in the morning. So you can, there may be as a hint that in the morning she's more in range, like maybe because of the dialysis procedure. Okay, we have our last polling question, which is, why is the hemoglobin so low if the mean CGM glucose and GMI are so high? Oh, yeah, I'm sorry. Yes. Yeah, sorry. Why is the hemoglobin A1C so low? Is it because of her use of ESA, her anemia, use of IV iron, or all of the above?
All right. ESA, all of the above. Yes, and I think based on Leela's first talk, I think you can make an argument for all of them, and all of the above is probably what I would vote as well. So here are some questions about this case. You sort of answered the first one. Why do the mean glycemia metrics, like hemoglobin A1C, differ compared to the clinical values in the CGM results? So the hemoglobin A1C probably is falsely low. The random glucoses that we get on monthly labs are taken one time of day. They were being taken during that interval when she actually was maybe okay, although even the glycemic control then was not okay. So those were not giving us a good reflection of her overall glycemic control. If anybody has responses to these questions or other questions, jump up. But otherwise, I'm going to go ahead and give our thoughts about these. Are the CGM results surprising given the clinical presentation? Well, when we first saw them, we were surprised. I mean, this looks like someone who has no signs that their glycemia is out of whack. After seeing all this happen over and over again in this study, we're no longer surprised, and this seems to be a common phenomenon in dialysis patients, and one that we need to understand better. Are there lifestyle modifications that can improve glycemia? I suspect there are people in the room that know that better than me, but clearly diet does matter, and you saw in a lot of these glucose curves that a lot of the hyperglycemia is later in the day. So I'm sure simple carbohydrates, simple sugars, there are things that could be changed, I suspect, to control this diurnal sort of approach, or that could be combined with pharmacotherapy. And if anybody wants to volunteer those, feel free. What pharmacologic therapy or therapies could be used in this patient? And, our hands are tied a little bit, and we don't know about SGLT2 inhibitors. They probably don't do much for glucose in dialysis patients. We can't use metformin because of risks of lactic acidosis. So there's a lot of insulin with the diurnal sort of focus. If you were going to start an insulin, you might start a prandial insulin, a short-acting one that's used with meals. And actually, that's what this patient did after participating in the study. We returned her results. She got hooked up with an endocrinologist, and she started prandial insulin to blunt those spikes later in the day. Another interesting question would be GLP-1 receptor agonists, which boost sort of postprandial insulin secretion and treat this pattern and haven't been very well studied in dialysis patients. Is there a role for repeat CGM or real-time CGM in this patient? Again, there are the regulatory caveats, but I think I could make a case that we had no idea what was going on with glycemia using the clinical measures. So if we're going to make a change, how are we going to monitor it? How are we going to follow it up? We have to do something again. So at least another blinded CGM to see whether whatever we decide to do works. Real-time CGM, of course, is also very powerful. And if you think about connecting glycemic control with diet, exercise, the timing of administration of insulin, it offers very powerful options to help refine those things, and might be a good option for a patient like this as well. All right, we have one more. I think in 3 minutes we can do the last case. All right, this is also a patient from the Blossom study, a 31-year-old male. Had kidney failure due to type 1 diabetes that he'd had for 23 years and was using peritoneal dialysis. And his prescription was dextrose dialysate overnight, and then he was dry during the day. He did have residual kidney function. He used a combination of short-acting and long-acting insulin. He was not on a pump, so he's on multiple daily insulin doses. He used a number of medications I won't go through. He had a hemoglobin A1C of 6.8% for what it's worth. And again, that seemed to be biased low, and that the mean CGM from his blood glucose was 228 milligrams per deciliter, equating to a glucose management indicator of 8.8%. So this is his, this is not the average, this is multiple days back to back. It's 5 days shown in a row. He participated in this accuracy study that we talked about, and so there are actually two tracings here, a blue one and a red one, the G6 Pro and the G6, and I'm colorblind, so I can't see any of it, but they're kind of superimposed. They go very well with each other, but what doesn't go so well with them are these black dots, which are, I mean, some of them do. These are the fingerstick glucoses. That one's fine, but you can see some of these are quite a bit off. And in fact, this really was not a lot of concordance in this particular patient between the self-monitored blood glucose and the CGM. So, Leela, I'll let you address these questions to finish this off.
Sure. So first question is, why is there such wide glycemic variability? Well, I don't know, but I showed this tracing to my friend Dr. Earl Hirsch, and he immediately said, oh, this person is injecting their insulin postprandially. And that was what is leading to this wide glycemic variability. And I believe he actually knows this patient and so knows that from history, but I was also able to see it from the tracing. Why does the CGM not match the self-monitored blood glucose for this person? Well, because CGM is changing so rapidly. You know, CGM is measuring from the interstitial fluid, not from the venous blood glucose. So it takes time to equilibrate. And when the glucose is changing rapidly, it's sort of like the CGM can't keep up. So if you go back, you can go back to the tracing. If you look on, say, October 13th, there's this really tall spike. Yeah, exactly. Yeah. And so although the CGM is saying that he was down around 100,
Yeah. It took the
Yeah.
CGM a bit of time there to catch up to
Yeah,
where the
exactly.
blood glucose was. Yeah.
So the CGM tends to do best when it's not changing rapidly, so in periods like that. So I would say that's one of the limitations of the CGM that we just have to be aware of. And then, is there a role for a repeat blinded CGM or a real-time CGM for this patient? I think in particular for this patient, the real-time CGM could be useful to, reinforce those lessons about the timing of insulin and, provide feedback.
And really, it's a standard of care now in type 1 diabetes, and hopefully would help him match his insulin to his eating and glucose better. So, all right, that's all we have. I think we're done, so we would like to respect your time and let you go, but we can hang around for other questions if you have other questions about these topics. Announcement.
And I'll let you go.
Okay.
Not like I can stop anyone from leaving, but just a few quick announcements. Please remember to complete your evaluations, the pre-test and the post-test, on the mobile app or the SCM portal. And remember, your CME credits must be claimed by June 22nd of this year, okay? And I've known from people in the past, they miss it by a day and there's no way to get them back. So please get them in by June 22nd. And I do want to remind people, look in your badge, there is an exhibit hall networking reception tonight from 5:30 to 7. There should be a free drink ticket in your badge that you can use. It'll be, if you were here last night, there's pretty heavy hors d'oeuvres. So there's quite a bit of food and one free drink, and then you can buy more if you'd like. Thank you again for your attention, and any questions, come on up.